Dr. Hessburg, it's a privilege and a pleasure to have you here in this interview. My name is Dr. David Seftel, and I'm the Research Director for the Macular Degeneration Foundation.
It's a pleasure meeting you.
Just for the videotapes for the editors, if you could just give your designation, your position at Detroit Institute.
Well, I'm now the Medical Director of the Detroit Institute of Ophthalmology. In June, the Institute merged with the Henry Ford Health System, and so now I'm also on the senior clinical staff of the Henry Ford Health System in the Department of Ophthalmology. And the Institute has become the research and education division of the Henry Ford Health System.
Henry Ford has been a pioneer in many ways. One of the areas that they've been a pioneer in is electronic medical records.
That's absolutely right. That's because Jack Guyton, who was originally from Johns Hopkins, came to the Henry Ford Health System in the early 50s, and he was a mathematician whose hobby really was ophthalmology, but his great passion was mathematics, and he became interested in the computer and in information technology long before anybody else saw any practical purposes for it. And in those years, he was a consultant to the IBM Corporation. The IBM Corporation initially built machines that had gears and wheels and pulleys in them. But when they converted to an electronic company, they had a handful of mathematicians around the United States who were given assignments which were purely mathematics related to the possible management of data electronically. And Jack Guyton was one of those. Later on, he started an information technology department within the Henry Ford Health System. If they had been wise at that time and known what a genius they had on their staff, they would have surmounted some of the problems that they later faced.
It's very interesting because there's a huge gap between what Henry Ford does and what the rest of the nation does. And misinformation or disinformation or lack of information between healthcare providers and institutions is a major problem in the delivery of quality care and cost-effective care. We're still wrestling with it.
I know you're wrestling with it, and I know that at this time, just last week, the Henry Ford Health System, which has a very dynamic leader in Nancy Schlichting, announced that it was beginning merger discussions with the Beaumont Health System that would make a $6.5 billion healthcare system in Detroit. And it is interesting that Beaumont has the Epic system already, and that the Henry Ford Health System some time ago decided that the system which it had worked with, in fact, I think it built it, didn't really answer its needs, and it is now going to Epic, which is a huge undertaking for the Henry Ford Health System, a very expensive one.
Now, talking about ophthalmology and the needs of ophthalmologists in terms of the information that they disseminate and the information that they collect, did Henry Ford and Detroit, either independently or together, develop a system for record keeping for ophthalmologists?
I can't answer that directly since I'm too new in the system. I can tell you, though, that I am a former member of the Council of the American Academy of Ophthalmology. I'm no longer on it, having stepped off some years ago, but I go to all the council meetings and I go to the mid-year forum, and there's great concern at the depersonalization of healthcare through the computer. yesterday at the opening ceremony, we had a brilliant discussion of the physician-patient relationship delivered by Abraham Verghese, the author of Cutting for Stone. And his message had to do with the human importance of my relationship with Liz Trowerneck, my patient, and how do we maintain that in a system in which electronic data is tremendously important, but given the importance of electronic data, how do we get that data into the system in a way which does not debase the relationship that I have with you as a patient? An example, too frequently now in healthcare, the physician walks in, introduces herself, sits down, turns her back to the patient, and enters data. It absolutely destroys the human touch that the physician should have. We discussed that among ourselves informally at the council just yesterday, and that opens the way for a scribe. If I say to you, if I'm looking at you and I say, yes, I understand, you've seen flashes and floaters, rather than having my back to you as I took your history, or if I look at you with a slit lamp and I say, well, the cornea is clear, and the scribe can then take that and introduce that data. It adds another person to the team, perhaps. On the other hand, I'm so interested in the humanity of the patient-physician relationship that I personally, if I were to see patients using a computer, would want to figure out some such system. Since having been with, both my wife and I are at the age where we have seen physicians lately, and walking in and have the patient turn his back on you while he asks you what your problem was. Terrible. I recently had another interesting experience where my daughter had an acute back problem and was seen by Mark Rosenblum, the chairman of the neurosurgery department within the Henry Ford Health System. And it was a total patient-physician relationship in which he looked at Susie in the eye, he examined her the way a physician should, and didn't simply look at the MRI that was sitting in front of him. That says to me, that's the way medicine ought to be practiced.
I agree with that. One of the things that struck me, I was trained in the British system, where you had to be able to talk to a patient and examine them and determine a diagnosis without looking at the labs, without looking at the x-rays. The clinical diagnosis or at least a clinical narrowing of the diagnosis was absolutely imperative. When I did my residency in the U.S., physical exam was an optional course.
It wasn't when I went through medical school. Physical examination was not optional, and had I listened with a stethoscope to a lady with her clothes on, I think I would have been dropped from the program. We didn't do that. We listened to the breath sounds of the back in a way in which you couldn't confuse rals with the rattle that comes with blouses. I have a great deal of trouble understanding where we've come, where somebody palpates the belly with their clothes on.
Absolutely. So in terms of the medical education of young residents, of young ophthalmologists, how do you structure the program to make sure that they don't lose sight of the critical human element?
That's a really good question. I think it would better be asked by young David Goldman, who is the physician who has now been assigned to follow me around now that I'm back in the Henry Ford Health System. He's in better contact with the young physicians than I am. I tell you what does worry me a great deal, and that is that that the pressures on the young physicians in order to make a living are such that the young physician is being urged to see more and more patients in less and less time. I have grandsons now in medical school, and I worry about that. I've always said I've forever interviewed young physicians going into medicine, and my advice to them has always been that if you go into it for the money, you're making a terrible error. But if you go into it for the fulfillment, you'll find that it is a wonderful place to be. But it isn't fulfilling to be told that now you're seeing 40 patients a day and we're going to increase that to 50 in order that the system can make money. Because there comes a point where it's no longer fulfilling to see the patient and to say, okay, the tech will tell you what's the matter with you and will help you with that isn't fulfilling. Then you become become another instrument in the system, no different than the Guyton tree finder or whatever. I talked to a young man recently who is a premier surgeon in Berlin, and he does up to 20 cataract operations a day. He's never met the patient before. He meets the patient as they're in the operating room. He does the surgery, and he never sees the patient again. That, to me, is not fulfilling. That's making the surgeon into he might just as well be a pair of forceps, or it's. So where does he get the wonders of medicine that I've always had, and that was dealing with a patient that I've operated on, who I've made see again. You're not going to get that if you've never seen the patient before. You don't know about their wife or their family or their children, or why it's important they have the cataract done when their vision may be 20/20 because he's a pilot on Northwestern Airlines. That's lost in a situation like this young surgeon told me about. I know enough to respect him greatly, but I don't respect that kind of care.
And that leads me to the next question. As you know, at about 2 o'clock this afternoon, there'll be a discussion here about the impact of the fuller implementation of the new healthcare plan and what it means for ophthalmologists. What are your views and concerns going forward?
Well, I worry a great deal about several things. The first one is the decisions being made by an independent group, the IPAB group, the Independent Physicians Advisory Board. These, as I understand it, are, excuse me, are 15 non-physicians who will make the determinations relative to whether this or that procedure is of enough value to warrant its conclusion. Now, I can see where we'll have trouble with a patient who's 85. Should that patient be given a pacemaker or not given a pacemaker? That's going to be a very human consideration. I am 82. I still lead a very active life, but when I'm 85, maybe I won't deserve a pacemaker. But on the other hand, maybe I will. And decisions like that coming out of the government worry me a great deal. I can remember lecturing in Sweden when I was with the chief of ophthalmology and we were making rounds. And at that time I asked him a question what is the interval between cataract surgery, between the first and second eye? And he said, that's an interesting question, but it rarely comes up here because the wait is so long for the cataract surgery in the first place that when the patient has had the first cataract removed, we rarely get to do the second cataract extraction because the patient doesn't live that long. Well, yesterday I heard an interesting talk by a very lovely physician from Canada who told us something which is interesting, and that is, he said, the patients don't seem to mind the wait. Well, the wait for cataract surgery, which he mentioned to us in Canada, is 312 days. Well, I can tell you, having been a surgeon in Detroit for many, many years, that wait was a lucrative business for us because many of those patients did not want to wait that long and came across the river, and we operated on them in Grosse Pointe. And it's a very interesting thing that a recent issue of the newsletter of the Henry Ford Health System had a picture of 6 employees whose business in the Henry Ford Health System was to expedite the care of patients coming over from Ontario into the Henry Ford Health System. So this physician may say it didn't matter, but it seems to me it mattered a great deal. Another thing that he mentioned was that the wait for an MRI was 3 months. Recently, the same physician that I told you about who saw my daughter said to Susie, I'll see you on Monday afternoon. On your way, stop at this clinic and they'll do your MRI. When you get to my office in West Bloomfield, I'll have the MRI and we'll tell you about what has to be done. Does your back need surgery or not? This, I think, is about her 12th episode of debilitating back collapse. And so you could say to Susie, okay, 3 months from now you can have your MRI, or you can go across the river and Dr. Rosenblum will do the MRI that day and we'll see you. So that worries me a great deal about Obamacare. Will we know about that? Not until we see the regulations. There's going to be 1,000 pages of the original document, and then everybody predicts 3,000 pages of regulation. And until we see those regulations, we're not really going to know what the effect of Obamacare is. I do know this, that because I was a flight surgeon in the Strategic Air Command, and our temporary duty base was at East Kirkby in north of London, I came to know London. And I go to London once or twice a year. You trained there. Well, I also know that every subway that I get on in London, the car has an ad for a supplemental insurance system because so many people in the National Health Service really aren't all that happy. They want to go see somebody on Harley Street. In order to do that, they buy a supplemental policy. Now, I'm told by an esteemed attorney, friend of mine in Des Moines, that the system is not going to allow the Harley Street physician model in the United States. And if that's the case, I worry how satisfied the American public will be with Obamacare.
Switching to macular degeneration, which is a major focus for us, a major focus for you as an organization. We've heard a lot of very promising work that's been done by a variety of researchers. Are you satisfied that there is enough research funding and enough focus on innovative approaches for AMD at this time?
That's a question that's, there's many colors to that rainbow. Am I satisfied? I suppose never. On the other hand, I don't, I think the National Eye Institute has done a superb job. I worry greatly whether the NIH and the NEI will be crippled by the sequester changes that are coming. That worries me tremendously. I think this. I believe that that macular degeneration is a whole lot of diseases, and the problem has worried me for a long time because. In fact, it's why we started the Detroit Institute of Ophthalmology, because ophthalmologists too frequently use the phrase, nothing more can be done. It's a phrase that I've always hated. And the phrase is a way for the ophthalmologist to tell the patient that there's no medicine, there's no surgery, but there is more that can be done. And one of the things that Liz Trowernick knows is that the Detroit Institute of Ophthalmology runs the largest support groups for patients with macular degeneration in the United States. They're the largest for a lot of reasons. First of all is we don't charge the patients, and secondly, we don't limit the number of times that the patient is seen. So they can be in the support group from the day they think they need it until the day they enter paradise. And those support groups are a tremendous lifeline for these patients. The other reason that they're large is we provide the transportation for them, because the patients with macular degeneration almost invariably lose their license to drive, unwarrantedly lose their license to drive, because if you look very carefully at it, the relationship between visual acuity and the driving licensure is very peculiar. In the 20s and 30s, when the automobile was coming into widespread use, we thought we ought to really know whether patients needed to have some level of vision in order to drive safely. And nobody really knew what it would be. And so in a way, almost like a dartboard, we threw darts at various levels and settled at 2040 and 2070, and that became sort of the rule of thumb around the world. But there's no data that shows that somebody whose vision drops to 2050 or 2060 or 2070 or 2080 has any increase in crashes. And so if we take the patient who has vision of 2100, okay, and we say to them, you can't drive anymore, what we're doing is we're saying, okay, you can no longer drive, and so therefore I'm taking away your independence. Because in this modern society, not in London, but certainly in Detroit, if we take away your driver's license, your independence is shattered. If your independence is shattered, that means that all of a sudden your elbow hurts and you've got to see the orthopedic surgeon, and I feel a little faint, so I think I ought to go see the internist. And not only that, become you socially isolated because you can't do your own shopping, you can't go to the movies, you can't go to the bridge club. And so all of a sudden we take a patient who is independent and we convert them into somebody who's not only independent, but who is not only dependent, but we turn them into someone who's depressed. Okay? So there is something the ophthalmologist can do. The ophthalmologist can say, we think you need a support group, just like an alcoholic needs a support group called AA, or a patient with breast cancer needs a support group, which they have in breast cancer, pink groups. So in ophthalmology, though, the support groups can play a huge role. And that's what we have done with the Detroit Institute of Ophthalmology. But we've done something else, and that is we started a World Congress called the Eye and the Auto, trying to get licensure groups to take a realistic look at what the guidelines for licensure are. And we've done that over and over again, and we're going to do it again next September. And that is bringing together the people who work with vision and driving to Detroit to discuss not only what the licensure limitations should be, but what we can do to understand better what that equation really is.
Well, that's a critical dimension, because the insurance industry, as you know, accumulates data on who gets involved in accidents. And invariably seniors, because of the experience that they've had on the road, have a much lower incidence of motor vehicle accidents. So from an actuarial perspective, we're actually dealing with a safer group. So the fears of visual impairment causing motor vehicle accidents may be overwrought.
We don't know the whole story, though. I can tell you this, that as an ophthalmologist, if I saw a patient who I thought was shaky relative to driving, no physician gives or takes the licensure. But I would often talk to patients, and I can tell you that the way that the patient views driving may explain what you have just said. For instance, if I have macular degeneration and my vision is 20/70, first of all, I quit driving at night. Okay? The next thing I quit doing is driving on the interstate system. The third thing I quit doing is driving in the snow or the rain. The next thing after that is I give up driving when the children are going back and forth to school. And lastly, I quit making left turns. And that pattern is almost invariably the case, so that the patient who is in her 80s, who is now driving in Grosse Pointe, who has no worry at all about crashes or killing children, follows that pattern. Okay? And she's not a threat on the road. Should we take her license away? I'm not sure you should. I have tried very hard to get the state of Michigan to change the licensure, and I've been on the medical advisory board to the governor and have argued as persuasively as possible to get them to change the laws. One of the things we should do is have cognitive tests, and the cognitive tests are reflected in the fact that we've changed the name of the eye and the auto to the eye, the brain, and the auto. Okay? We've done it for that reason, because I can tell you that I see and know seniors whose vision may be 20/40, who ought to be off the roads because their wife is telling them, okay, Charlie, make a left turn or make a right turn, or you're not aimed at church, you're trying to go to the beauty parlor. So cognitively they ought to be off the road, but not because of their vision. So this interrelationship between the vehicle, the driver, vision, is a very sophisticated one. Look at the new cars. The federal government mandates now that in a crash, the A pillar on the vehicle is wider than it used to be. Okay? Well, the A pillar it presents a real problem, because if you're driving along the expressway and a vehicle is entering the expressway to your right and the A pillar on the right obstructs that vision, all of a sudden you're surprised because there's a new car entering the expressway that you didn't see because that vehicle was lost in the A pillar of the vehicle. So the problem is now compounded by the design of the vehicle itself.
That raises the question, is there a potential role for a new category of licensure? Right? Restricted license, a license that would be applicable to the types of conditions that you say
absolutely
already adopted.
Absolutely. And some states use restricted licensure very carefully, and I'm not going to name states and get in trouble with licensure bureaus, but some states think it's too much work. Okay? States use it a great deal, and I think absolutely I'm very much in favor of states that put a test driver next to the driver in question and give them a road test with a driver in the car and say, okay, I want you to drive to Main Street and 3rd Street and park. Okay? That, I think, is a legitimate test. But to put the patient in front of a piece of paper and have them do 3 or 4, I can tell you that The cognitive test that I really favor is a test like a clock test. If I hand you a sheet of paper on which there's a circle with a 12 at the top and say to you, put in the numbers of the clock, and you spend a minute and a half going from 12 to 3, and then you're going from 4 to 8, takes another 3 minutes, I'm going to say, I think you ought to have an on-road driving test. Now that makes sense to me. Okay?
So the final element in this discussion is, what can patients do about trying to move the legislatures in the right direction? Is there anything they can do?
Can patients do to move it in the right direction?
State propositions, for example. In California, there are lots of propositions that come up during the elections. Is this an avenue that is being explored by anyone to your knowledge?
The reason that I hesitate is because the Detroit Institute of Ophthalmology is an IRS 501c3, and as such, we are not allowed to have anything to do with legislation. And so I think that I think that I'd be quite comfortable telling the patient to have a realistic discussion with their physician about it, and to have their physician look at the internet and see what the eye and the auto, what those lectures, they're all up on the internet now, and I think that I'd much rather have the patient interfacing with their physician than trying to interface with the legislature.